Okay, so I think we are running exceedingly late, so let's start. So these are the panelists. So, and you've met all of them this morning, and I think not a single one of them needs introduction. So we'll skip on Pramesh and Sudeep, both not here. They got, and Vedang, I think, also isn't here. So can we go to the next slide? So let's start with this. Is research important? So I put a list of reasons that all of us come up with not to do research. And this is what everybody, all my colleagues tell me, my residents tell me. Why do we not do research, especially in an LMIC? So sorry, there's no time. We have huge patient numbers. We are in the OPD morning to evening. There's no protected research time. There are no resources, no staff, no funding. We don't have new technologies. Drugs aren't available. We don't have writers. We don't have tests. We don't have statisticians who are partners with us, who can sit with us and develop protocols. There are no incentives. So if you do research, who cares? I mean, it doesn't help with your promotion. You don't get any money. You more or less use your own personal time after hours to do it. There are excessive regulations, there's the publication bias. Even if you complete your study, there is a publication bias. And I'll show you a few. So most of this talk is all my personal experience and my personal examples. And there's no understanding really that in the community that research is important. So, patients don't understand, there are no patient advocates. And in our country, in LMICs, that's really a big thing. So I know the issues are different, but relatively similar as well, globally as well as in India. So I'd like comments from the panelists as to what are your thoughts about this?
Well, I think that, first of all, we only get better by doing research. Secondly, I think in terms of the patients, there's fairly good evidence that patients who participate in research do better than those who are not participating in research. And there can be selection biases for that because patients are selected to go on clinical trials. But I think that they're better looked after. There are various reasons for that. So I think in terms of patient benefit, then that needs to be spread. In terms of some of the...
Any specific tips as to how to spread that? Because, I think out of maybe 10 patients that I would counsel to come on a trial, 8 of them would say, no, I don't want anything experimental. If it is not what you're, I don't want to be on a trial. And that's, I think, perhaps maybe the experience of many researchers here. So any tips that you could give us as to how to deal with that?
Well, I don't want to monopolize the conversation. I haven't practiced in India. Certainly, I think the experience in Canada is a little bit better than that patients are more aware of the benefits of trials. How one encourages that, I think, is, to try to, with the Tata Memorial Hospital, that it's known as a research hospital, and it's a good hospital because it does research. But I let other people talk.
I can't see the two of you because you're right behind my podium. So please jump in.
Yeah, so I agree with Vanita, and all the reasons she has listed down here. This actually looks like one of our WhatsApp chats. Why are we not doing any studies? So like you said, patients are reluctant. They are hesitant to join trials. That's true because, a lot of them have this fear that they will be made to do extra tests or extra visits. And a lot of patients who come to our hospital are from outside Mumbai. So I think that is one of the major factors. Whenever we try to counsel them, they think the follow-up is going to be extensive, or even the investigations that are going to be required. Even though they understand that research will help us find out which treatment is better and they will not be harmed, they are worried about the extra time and extra visits that they have to put in. That's what I have found.
Perfect.
In my experience, what I've found is that a lot of the people who say no to participation today, especially in the standard of care comparisons, are people who are well-read. They are literate patients, but they kind of have caught on to the negative part of the furor created by poorly done studies.
Absolutely.
So that what has created a kind of apprehension that if they were to participate even in a standard of care comparison, it would do them harm. whatever it is. So because I've had recent experiences with some trials which are very pragmatic and which are just comparison of standards of care. So I think that is another generation that we're seeing now. People who are read, who know about trials, who understand things, and despite that, they're not mature enough to understand that it is also important. It's a societal contribution. I don't think that's there at all.
So I think we need that minimum voice. So I guess that's the bottom line. How do we get that voice? So the voice of the naysayers is so strong. Research is bad, and you're harming patients. How do we get the alternative voice in public? Vishal, Kumar.
So yeah, I think
I really can't see. I'm really
So that's
short.
okay, yeah.
My apologies.
yeah, I think the lack of participation from patients in clinical trials, it's an important issue even in high income countries. I think data show that in US, less than 5% of cancer patients are treated in the setting of clinical trials. So it's not only a problem in low income countries, even in high income countries, lack of participation is a problem. More than half of the clinical trials, they close prematurely due to lack of participation. However, I think one is absolutely about empowering patients with education. There will be a lot of misconceptions. Oh, am I going to be treated with placebo? What does control arm mean? What does investigational arm mean? What are the differences between phase 1, 2, and 3? So a lot of this is probably addressed by empowering patients with education. And I think even in countries like US, where patients are supposedly more aware, it is a problem. So, yeah, I think it is important to teach about the role of clinical trials. And the other solution nowadays is to focus more on pragmatic clinical trials that can be done within the settings of healthcare system and not necessarily, cause extra burden on the patients in terms of, if I'm getting the routine standard of care once every 3 weeks, but because of participation in the trials, I need to come to the cancer center once every week, or spend more time, and the cost of it, and maybe patients are expecting they are going to get free drugs by participating in trials, but in fact they need to spend more due to travel and parking and everything. So I think that all needs to be taken into consideration. But the only thing I wanted to highlight is it's not a problem for India or Tata alone. Even countries like US, even MD Anderson, they are struggling.
Yeah, I think just to expand on Vishal's point, I think that patient education is the key, and patient engagement. And I think two things. One is I talked about the Canadian Cancer Trials Group, and they have patient representatives are integrated into trial design, but also into trial promotion. So they help a lot in terms of getting the message out to patients, and in terms of design. So I think, and I've heard, we heard earlier this morning, that's an important part of the National Cancer Grid collaboration as well. I think the second thing is patient advocacy groups in Canada play a huge role in education and communication, and letting people know about trials, and actually highlighting the importance of clinical trials and the benefits of participating in clinical trials. And I'm not sure if about the status of formal patient advocacy groups in India. However, when we were visiting with Dr. Sengar yesterday, we were learning about this really extensive volunteer community here that helps patients in a lot of aspects of their care. And that's a group I would see that could be engaged also in informing and educating patients about participating in trials as well.
Yeah, just a couple of comments. So I think back to your first slide, but is research important? I think that's probably key to addressing a number of the challenges you've outlined there. So I think it would be helpful at many levels to promote the importance of this within the public, within patients, so they want to participate. But I think, I feel like we're in a hugely privileged position in the West where we have protected time and a huge number of resources to do this. And so I'm always amazed at my friends and colleagues that work in centers like TMH and elsewhere who are able to accomplish what they do despite the major barriers. And that is going to take a system and a culture change. I don't think it's not sustainable long term for India or any other country to expect clinical research just to develop on the back of very little resources. And so I think with advocating and spreading the message within the public that this is important to support and participate. It's also to support, the institutions and government funding agencies to recognize that and allow resources and time for all of our colleagues in LMICs to be able to contribute and have time to do it.
Dr.
Yeah.
Kumar and then Amol.
So I think sure there are many factors, but one important one from my side for investigator, and I'll use the words of Dr. Badvisar and then I'll make my comment. And what he always says that the busiest of the clinician does the maximum research work, and so if I say to him we are busy, he doesn't listen, and that's what his comment remains. And I think so partly it is true, not necessarily I'll agree completely. I have my colleagues in my department. But the second part is important, which I think, so seeing all the reasonings, someone who did the vitamin C study for scurvy, sure, lack of time, lack of resources, lack of statistical expertise, these were all problems for him. Incentive, thoda, excessive regulation, no regulation was there. But majority of the problem he had, and he could, that person could do it. So the message should be there. Research doesn't mean always pharma study. Research always doesn't mean that you have 1,000 patient study. We encounter every day in the clinic, and when we sit in joint clinic, every day we encounter 5 questions. Oh, why we are doing this? And then going back and trying to answer is important. So that connotation should be there, because we have made it a bit elitist. Research being that it is common should be part of it. So people do get concerned. But the younger consultant who joined, they do get concerned. This is something beyond patient care. No, this is a part of a patient care that doesn't come in the discussion. It looks like alagi CME hota hai iska, there's a separate CME happens, separate group of people who are there. I think so maybe that's one factor. This is more from my side. I'm sure there are many more. From patient.
I missed lack of mentorship on this slide.
So it looks like the senior like us have been non-mentoring well. So coming part to the second part of from the patient perspective, what they listen in the newspaper, television, that is far more than whatever we talk about. As much they read, and somehow at this moment that counter narrative has not been there, and at least in our country we can say the kind of NCCN you have, one line in every page being there. When the patient reads that what Dr. Tanak said, that participation in clinical trial improves outcome, that message doesn't go to them. I think so that awareness part.
Perfect. Amol, you had a question?
And I just wanted to make a point that when you talk about lack of incentives, we should talk about the incentives for the patients also, if it is possible, because that may improve the enrollment. Most of our patients feel that once the trial is over, they will be dumped and they will not be taken care of. So if we can convince them that even if the trial is over or they are out because of the progression, the further line of treatment will be taken care of. If that is possible, probably we can increase the enrollment of the patients into the trial. So the incentives for the patients probably needs to be increased if it is feasible, especially for us. Of course, we require more sponsorship for that, but if it is feasible, that should be looked into.
So, to clarify, so are you suggesting we incentivize trial participation, or just that the patient is taken care of?
No, the patient should be convinced that even if the trial is over or they're out of a trial because of an event, say in the form of progression, still their treatment will be taken care by in the similar manner by the institution. And there will not be any difference between the care before, because just because they are in trial, they are taken care very efficiently, and once they're out of trial, the care may not be that efficiently. So if that particular thing is taken out of their mind, maybe the enrollment may increase. So we need to think that what can be the incentive to the patient also, if it is feasible.
Agree.
Can I just make a point? Actually, Amol, if you look at it, the Gazette notification that came out in 2013 and then was published later on in 2014 actually lays emphasis on that. And that's why it's important that the informed consent forms actually include that, as that you know what is the standard of care, you know what it is that is happening to you on the trial, and then after trial, either because of progression of disease or lack of benefit or whatever, you will still be continued to treat on the existing standard of care, and that will be as per routine. So it became very important for us and also the informed consent to have this line about standard of care and continuation of care even after trial participation.
I think the point Amol was making is that we take it for granted. Of course, I mean, these are our patients. Of course, we'll continue to take care of them. But I think you meant we need to reinforce and make sure that they understand that, right?
Yeah.
Dr. Tanik.
I'd like to ask the residents at the back. You've heard a number of your more senior people at Tata standing up here, giving results of research, showing some papers that have had international attention. How many of you just want to be, I shouldn't say just, but how many of you want to be an oncologist who looks after patients and takes no part in future advancing of research? Or how many of you, despite the difficulties, will aspire to be the people that you've heard talk to you today, who clearly done more than look after patients and establish some advances in care for the future?
Yeah,
So how to be the former?
of note, the
It's a
director
trap.
is supposed to be here, but he isn't here. So feel free to tell the truth.
How many of you would really like to be doing research in the future? How many would not like to be doing research in the future? Come on, you've all got hands.
It's binary question is yes or no. There's no.
I think a number of you would like to do research, and I think you should charge your senior people to make that easier for you. And obviously, lack of time is difficult, but sharing duties and things like that, covering one another, there are ways, even under difficult circumstances, to make it happen. And we see each year at Credo that there are a lot of people who do want to do research, and that's very encouraging. How we can make it easier for that to happen is difficult, but not impossible.
So I think in the interest of time, we'll go on. Dr. Kumar gave a brilliant talk on asking the relevant research questions. So I'll just recap, and then if anyone has anything to add, please do so. So to my understanding, the right question. So I think that is the key, ask the correct question, which will make a difference to your patient. So it has to be in something that is in your area of expertise and that is of interest to you. So in order to take, because research is tough, in order to actually go to the end, and it should be doable. So applicable in the patients that you see. You should have adequate patient numbers to answer your question. It should be relatively inexpensive. So if you visualize something that costs crores of rupees, unlikely it'll ever get done. It should build on work already done. So sequentially continue to ask one question, which leads to the next question. And the results should make a clear difference to the patients that you see in your clinic. So, and a clinically relevant question, adding on to the points that Dr. Tanik had made. So other than improving survival and improving quality of life, important for our patients also would be lowering toxicity or logistical, less requirement to come to the hospital, less cost, less manpower, etc. And should change the way we practice. So any comments on that, or we can go on? Vedant, yes.
Just the point about the right question, and also somebody made the point about we see questions every day in the clinic that we'd like to have answered, and it doesn't always have to be a new treatment or something along those sides. One of the first research projects I took part in was I was having difficulty explaining to patients why we couldn't offer some drugs because they weren't funded. And so one of my first projects was to do an interview study of oncologists about how they felt about that. What were the reasons for that, barriers and ways to improve it. And we just talked about something, why aren't patients being more involved in research? What a great question. Why not, a great study there would be to talk to patients and interview them with the appropriate supports from, probably somebody who's done qualitative research. But that's a really great question right there. I think you could do a sample, a pilot, just to get an idea, apply for grants, etc. But that's a great question to start with. Why? What are the barriers to research?
So I did think about that a couple of years ago, and I was so scared of what the results would be, and I put it on the back burner, and I said, I'll get back to it in some time. You wanted, Amol, you want to say something or? Sorry. Getting old, forgive me.
Just adding to what you just said, research. I mean, we've all heard that research doesn't mean a trial. I mean, when students leave after their training, they always, many of them tell me, we want to continue to do research, and what should we do? And I tell them that, look, you will be treating head and neck cancer and breast cancer and cervix cancer day in, day out. You, over a couple of years, you would have treated 200 patients, or they come back after 2-3 years and they said, we want to do research. How should we do? I said, do you know in the 200 head and neck cancer patients that you treated, what is the outcome that you have? What is their survival? Have you cured them or not? And almost nobody has an answer to that. So I think the best thing would, and I wonder why they don't do it. I think a lot of it is they don't have what Kumar said, mentorship, and they just don't know how to do it. Collecting data, looking it up, maintaining it, it needs. So I think the right question for me would be, for the grassroots oncologist, would be to find out what is happening to your patient and audit. That is research enough.
Absolutely. So you start with that always, and that's what we started.
And nobody does that. Nobody does that, or very few people do that. So I think that's where we can focus on.
So I completely 100,000% agree with you. And I'll say when I first joined in the first couple of years, all we did was audit, enter into all databases, what our patients were doing. One of my very senior colleagues, actually, two of my senior colleagues called me and told me, Vanita, you are just a data entry operator. And I said, I don't care. I will continue, because this is really important. And that led to so many important things. I'll ask Dr. Kumar to comment on that.
I totally agree. You need to know what is happening to your patient. Then only you know what is the problem, and then you provide a solution. Absolutely, no doubt about it. Because especially in the country like India, when you have 100 patients every day in the OPD, always feel that you have done all good for patient, because every day there are 100 patients. What happened to 100 of them? Did those 20-30 didn't come back? And why they didn't come back, when you go through that data and databases, and then you call them and you find out. Absolutely right. We have learned a lot, and I know what you did, and also the emphasis from Dr. Badwizar's side. He is after this, what has happened to your patients? I'll give you three examples for the questions which comes in the OPD by three of the different colleagues. One by Dr. Vanita, that's a navigation study, and we know navigation in India is different from navigation in United States. With our navigation team, we are running a randomized trial. How to see that? Because I'm sure you might have all gone through our hospital. Going to 5 places and getting things done is a bit tedious for patient, knowing where to go. So we are trying to have a navigator who does the patient initially. They come and they are showed everything. We'll come to know after some time, does the treatment starting comes early? So outcome is quality of life is the outcome. Quality of life is the outcome. Not sure it will come out better, but we're looking if the treatment starts early, that is also good for patient. So let's see what comes out. Because why it happened? Because we did realize when we see in the audit, I can't say the number, it doesn't reflect good on us. Good number of patients went far beyond the time period which makes us comfortable when we started treatment. Second is by one of my colleagues in CNS tumor. CNS tumor in COVID time. It was not easy for them to come. Anyway, no one was coming, and CNS tumor hardly, it's not easy for them to travel. He did a randomized study comparing video consult versus people when they came. Same patients, you do video consult, everyone knew they will come back. Trying to see decision making by the video consult, and there were some parameters which was done. And the best part was it looked like it is feasible and one can do it. Think about in Indian context where people comes in Tata Hospital from 2,000 kilometers away. Again, here, absolutely don't get me wrong when I say quality of life and OS as an endpoint. If they have to travel less. So there are different. So you again have an issue, which is here you have a problem. It's not easy to travel. Remember when India people travel, they leave their family there, when they travel, and with the whole group of other people traveling. Third one, a simple one, and which Vedang was mentioning. We did some initial work of, you saw the EGFR, we did in a squamous cell. It was positive in 5% patient. We got roundedly criticized internationally and nationally. No, we have not seen it. Today, NCCN guideline has changed the guideline that yes, you need to do molecular testing in squamous cell carcinoma patient, because that time those data were not there with them and they thought it doesn't happen. And it was simple because our pathologists gave the report, we trusted them, we rechecked them, we say, hey, it is right. We had 2 papers of that time, 10 years back, NCCN changed last year.
It used to always lead to very heated panel discussions because we used to always say we do it and they used to all say, how can
We had
It's not
Dr.
in
Chandra
any way.
Bilani, Dr. Tewani Mog say, Kumar, what you're saying. And I repeat today, go and see NCCN, its guideline has changed.
Thanks for those comments. I'm just going to add on, I guess, to 2 elements of that. And these comments are mostly directed at the trainees at the back of the room. I think that you can address projects again that are highly relevant in clinic. And so, often with regards to value, and I think this is really important and to be context specific in every health system, is there's a huge number of projects waiting to be done in the Indian cancer system, asking Indian patients, what do they think about progression-free survival, quality of life, overall survival, time toxicity, using language that a non-medical person can understand. A lot of expert doctors, we think we know, but we should actually be asking patients. So that requires, surveys, qualitative mixed methods that you need to find partners that know how to do that. But that's a huge, important piece of work. We're trying to do it in Canada. I think it should be done in every health system. So that's one form of work I think that'll be very high yield. And the other is, as my colleagues have said, is to understand how care is delivered in your practice or in your health system. And I spent the first decade of my career running a program in health services research using a large cancer registry to understand issues of access, quality, equity, and outcomes. Because if you don't measure something, you don't know there's problems, you can't fix it. And there's a very important paper. We can perhaps send it around to the organizers later. The title of the paper is something along the lines of the break-even point when medical advances themselves are less important than the fidelity with which we deliver healthcare. And what that gets at is all these new fancy robots and machines and antibodies and immunotherapies and blah, 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 fancy stuff that we do. The incremental gain of that is very small. But if you can ensure that all patients in the Canadian health system, the Indian health system, and the Nepali health system get access to the fundamental elements of treatment that we know work. Adjuvant chemotherapy for colon cancer, tamoxifen for breast cancer, et cetera, the things we know that have large benefits, that's where we can have the largest public health impact. And so those are some avenues I think that can be well explored both in your own clinical practice in the future, but also within the health system.
Perfect. So we'll go on. So coming to funding. So this is, I have a couple of stories. So the rest of the slides are pretty much my personal experiences of issues. So the idea of this is to try and understand issues. So the first was the 3-weekly study. So now this was the first study that I had written. This was the budget. And you can see that, so both the arms were standard of care. So it was 3-weekly cisplatin versus weekly cisplatin used in various different settings as a standard. So we weren't paying for the medicine or the investigations. All the funding was for personnel. So we did get, so the antibodies and solvents were for some PK studies, which never got done eventually. So it was a relatively small budget. We have a wonderful system at Tata Memorial in place that it's called TRACK. And so TRACK gave us some funding. So we got 10 lakh rupees and we hired a coordinator, brilliant coordinator, Dr. Vijay is sitting right here. So was able to, we managed it with one coordinator and our residents and our research staff. So we managed to start the study. In 2016, TRACK sent me a letter that you have not really shown an intent to apply for funding elsewhere, and therefore we withdraw funding. Now, the reason why we are unable to apply outside is for all of the reasons I put on our first slide. You're trying to deliver care to your regular patients, your trial patients, you're trying to do all the paperwork that's important, but regardless, so I did apply. So I applied to DBT. It was submitted to DBT and it was rejected from DBT. So we eventually did, it's a positive story. We eventually completed the study. It was an oral at ASCO and it did get published. But what happens to people who don't have access to this funding? So I was lucky enough that I had some minimal seed funding at Tata Memorial, but usual regular clinical trials, getting funding is very, very difficult. So I have another funding story. So I have this study on using adjuvant chemotherapy for CAPNS. So there is not a single randomized trial for adjuvant chemotherapy in CAPNS, and it is not a global carcinoma. It is an Indian problem. So we have a high proportion. It's higher than globally, but still it's a rare tumor. So funding for adjuvant CAPNS, it was rejected by TRAC, so I did not get institutional funding for this. I applied to DBT. It was rejected from DBT, and the suggestion from DBT at the time was, please apply to ICMR. Now, some of you in the room would know that ICMR had closed funding for several years. This was in one of those several years, and presumably the funding agencies would know that. So I've just taken a screenshot. So that was a time when there was no, ICMR was not accepting concepts for funding. I applied to some other international global bodies, and they said, no, there's no chance. We really can't fund your local study. So where does somebody go from there? So how does one obtain funding for a trial? So the other aspect is, do you really need funding, all the funding that you write for? So when I wrote the study, you always want to do biomarker studies. So there was VEGF levels, which clearly you would not do without funding. So our initial funding was a lot. The funding for the drugs was cisplatin and 5-FU. So probably cost few hundred rupees. So it was very small. So we managed to get a small amount of fund, which the number of patients we recruit on the study is small. So that was enough to cover it. But every year when I send in my continuing review application, I get a letter from my ethics committee that you have not arranged all the funds that you're supposed to arrange. How do you continue your trial? Why do you continue your trial? Don't continue your trial. So, and I'll just put a few pictures. Have you received funds? What are you doing? So what else could I possibly do? And, and I have access. I'm lucky enough to be at Tata. I have access to a lot of resources. What do other investigators do? So I'd like the opinion from the panel as to any kind of tips for this. Any personal experiences or... And this has to be a partnership, right? It has to be a partnership between the ethics committee and the PI. This is a problem. I mean, there is no other study in adjuvant CAPNS. So how do we go forward? Vedang, this is something that's close to your heart. So maybe you can.
There's no easy answer to this, clearly. I think one advantage we have as compared to those in the West is we can multitask, much more. We can adjust many more things that, especially in the investigator-initiated trials, one coordinator does 4 trials.
Amen to that, and thank you to that. I'm coordinators here.
Yeah, they are a blessing. Each one of them look after 4 or 5 trials. So that may not really happen abroad. But getting the funding, as I said, we are lucky. My suggestion would be to design and ask questions that actually don't need. Being a medical oncologist, that's difficult, obviously, to answer new questions about drugs. But as you said, the standard of care treatment, if we compare 2 standards of care, that is one way to do it. You can manage.
Aren't you completely limiting yourself in the questions you could ask?
But at least something will be done. An audit doesn't need your study, your QOL or your patterns of care. That doesn't really need funding. So maybe you start there. And then as you build your portfolio, as you build your experience, maybe somebody will be kind enough to, fund you when there's an important enough question. So I think that would be my...
this is a real area of need, and I would say that I've been trying to build my portfolio. Maybe it's not great, but I'm still not been blessed with the funding. So
I think so. This is a challenge in India. We don't have, the moment all the research funding from DBT, what Dr. Vanita showed, primarily goes to related to biological work, and that somehow is a challenge. That doesn't mean there is no such funding, but very little, very far and few. I did have a discussion with DBT person. He showed me 2, 3 and he said, "Dekho, humne kiya, we had done it." I said, "Come on, don't tell me in 15 years you did 2, 3 and but it looks like they are more concerned about biological questions." So there is a challenge about having funding. And for me, I think so. What we need to learn from West, that they change as per the situation changes. And again, a very good example from NHS. NHS currently running a protocol of proton versus non-proton. Now, all proton versus non-proton, proton is by NHS. They say, if you get randomized, you don't get proton therapy. So who's doing that? It's the United Kingdom government is doing that. What it means that everyone is a stakeholder. It is not a one PI who becomes, because he or she is the PI, he becomes responsible for everything in doing a study. That part we have not changed here, because we do get a good number of patients who are taken care by government funding. But idea is that the moment the patient is in the trial, you say, hey, where the money comes from? But that part, first part we learned very well from the West, that, inter-trial, intervention arm, you need funding. But we didn't learn when they had a problem and they were willing to change. They say, hey, patient doesn't pay, if it comes from NHS, is good to do a randomized trial in that setting. And apart from that, the patient also being a stakeholder. We are thinking here only PI and institution drives it. The society and the patient not being a stakeholder, maybe not the right way to go as far as definitely India is concerned. West, they have done a good job of having advocacy group. We hardly have any. But they being a stakeholder, and I do come across patients in the OPD, they do question me. Somehow for them, the reach to IC is not there at this moment, which should be there. They say, hey, I want to get this treatment. I'm willing to pay for it. They say trial is over. I say okay with it, but I'm willing to pay for this drug. But do we have that modality open in our system? That modality is not open in our system. In fact, just around a year back, I got one funding from Merck for Evolumab. And Evolumab was not marketed in India at that time. So it was investigator-initiated study, so they funded it. Then I realized we don't have a system in place where you have an investigator-initiated study where a drug is not marketed, and if someone is giving a drug from outside, you can do a trial. As much we went to DCGI somehow because it's an online system, so there was no way to change the system by paper. So we do have that issue regarding it. Resources being available, we have by rules, we have limited the resources. If you ask me, we need to learn from 1991. That is, before that, our industries were choked because of rules we had. Research, we have a similar issue at this moment. Not exactly the way DCGI was, it has improved a lot. But overall, the awareness of the rule and interpretation of the rule and implementation of the rule, we have an issue regarding what we had as far as the economy is concerned before 1991. You choke the system with such kind of rules and regulations that anyone who is interested in doing that, they don't do it. Similar, we have in study. We have 30 regional cancer center, and I have gone to 3-4 of them. It is very tough to find out that every of them has a randomized trial. We don't. And the reason is, it's not like people don't want to do what you're showing is right, that you have a system where the rules are such that it chokes the system in a way that all onus is on PI, and then PI is scared and worried that I don't want to do study.
Yep. I just wanted to raise a point that we always talk about lack of funds because we are in an LMIC country. Probably what is the issue is that it is not that we don't have money. We have a lot of money. If you see, we have around 100 conferences done in a year in this country, and we have, if you see, at least individual conferences probably spending around 80 lakhs, 1 crore. So if you calculate that money, that itself comes to 100 crores. So if you decide to utilize that money for a better purpose, we will have lots of funds allocated for research. But the problem in our country is that the research and the researchers are looked down upon, And our priorities are probably slightly different. As we have been pointed out, that we do not have a single organization who probably represents medical oncologists. We have multiple organizations. The funds which are available get divided. The funds are more focused on arranging meetings rather than doing exact works. So it is not that we don't have money. We have money. India is probably a rising economy. Probably we are in number 5 or 6 as far as the world economy is concerned. It is not that we don't have money. The money is not probably allocated properly. We spend it on something which probably we should not be spending on.
That's why you should have Amol in all panels.
I know. I'm very grateful. The slides are not moving. It's do you know how to do this? Ah, sorry. So now it's going back. Okay. So coming to the next issue about timely approval from regulatory bodies. So I think Dr. Kumar had given us one example of the letrozole story in which we had to scrap the idea because we just didn't get approval from DCGI. And I have one local story for you. Is that so? Geriatric oncology is very close to my heart. So I had written this study in early 2020 and finally managed to submit it to the ethics committee in June 2020. So, and it's a very simple concept. In my mind, we are overdosing patients in the geriatric age group. So the question was full dose chemotherapy, which is the standard, and the investigational arm would be a lower dose chemotherapy. So very, very straightforward, simple design. Submitted in June 2020. I got multiple questions from the ethics committee. I wrote to Ravi Kaneswaran. So if any of you know geriatric oncology, there is a global geriatric oncology body called SIOC. So it's the international, it's written in, it's in a French name, I guess. So it's an international geriatric oncology body, and Ravi Kaneswaran is the president of SIOC. So I wrote to him, what do you think about the protocol, and do you think this is appropriate? So, and he said, he read through the protocol. He said, I completely agree. It's a difficult trial to do, because in this group of patients, it's doing trials is difficult. But please go ahead. So this went back and forth. I got questions from the ethics committee. I wrote back. I got questions. Note the date. So I finally, in Feb of 2022, I finally wrote, I have submitted this project 2 years ago. I have not got approval. Call me. If there are any issues, I will explain. In response to this, I was still not called. In the 2 years, I wasn't called. And I'm happy to say that I was at ASCO this year, and I was so excited. This was more exciting to me than anything at ASCO, that I actually got approval in June 2022. So, comments. How do we do this? How do we make it a two-way street communication? This is not helping research in any way, right? Any comments, Dr. Sabani? I'll give you the. And in spirit of full disclosure, Dr. Sarbani was not the ethics committee secretary at the time, so she's just inherited the IEC now.
So the only thing, Vanita, I can say is ethics in this institute has essentially always been pro-research. I can say that because I've had 2 terms. This is my 2nd term. And I think we've been pro-research. Sometimes some protocols do take longer because, even we ourselves have matrices in place in which we measure our efficiency and our efficacy. Because we look at our turnaround times, we look at timely submissions, we look at timely issuing of orders, and also because we are an accredited body, it is imperative that we also give you our decisions on time. So I'd only like to say that for myself and my colleagues as well as my predecessors, I would only say that I'm sure there must have been something. I don't know why things took so long, but we've been trying to see to it that we do stick to our turnaround times. We do issue. We try to be as pro-research as possible because the main focus then happens about the methodology and just being right by our patients, because that becomes the first consideration. And of course, a lot of time, this is a committee decision. It's not an individual's decision. So I'd only like to say that in our defense, But
I'm absolutely with you. And there's no question about it. Then there could be innumerable issues. And of course, you'll have to deliberate about it. My only point is, let's make this a two-way street. However long it may take, and I don't know if it would have this would have fitted into those matrices. I hope not. Regardless, I mean, if my understanding, so if the domain expertise may or may not be there, but let's discuss. I think that was my bottom line.
Okay, yeah.
Any other comments or any other experiences?
I just want to make one comment that, of course, as a researcher, all of us sometimes feel frustrated that it's taking a long time for final ethical and other regulatory approvals. But my own experience has been that at the end of that process, almost always my protocol is much better than what it was at the beginning of it. And there are, many things that as researchers, we also have to learn. We have to put everything in order. We have to comply with all the standards that exist. And so that two-way process, I think a substantial proportion of that responsibility also lies on the researchers to conduct themselves responsibly. And I think at Tata Memorial Center, we are fortunate that we have an ethical review process that is not just a rubber stamp. It is a rigorous process, but at least I speak for myself that almost always my protocols are much better after that review than before it. So that's my submission.
Yes, Dr. Supriya.
I had this experience also with NRG because I coordinate many of the NRG US studies here. So these detailed, timelines, I don't think it's restricted only to India. There we've had documents moving around for months, just knowing who's going to sign that document because multiple organizations are involved. And I think that it's not something related to India. Overall in academic research, I think getting the workflows right, MOUs right, I think it's not the research question, but what surrounds in conducting that research. I think that needs to be streamlined, and it's very quick in pharma supported research, but in academia research world over is suffering. It's not only here.
Yeah, and isn't that the bottom line? I mean, in 2 years we could have answered, we could have completed this question and gone to the next. So I think that's the bottom line. I think so. Dr. Kumar, you were going to say something.
Just adding to it, what you said is true. That regulators, and this is true for any regulator. This is for HOD, for people in admin, people, DCGI, and DCGI became better because they interacted. Think about those rules, what they came up out of, and how much it harmed the research and the country as a whole. But if they had dialogue, then they did learn that there is an issue. It had to go to Supreme Court. I know a bit more details. I leave it there. But yes, the dialogue and willing to listen to each other, and this is true for everybody. Either you are in DMG, you are in department, you are in DCGI, you are in ethics committee, you are in DSMC. That listening to each other, why, what happened, what is required, it's very important to resolve it. If someone is not listening, you're not going to have any issue getting resolved. And I quote Shimon Peres. He was, Israel Prime Minister and Foreign Minister, got Nobel Prize, said dialogue is the only way. As much the Israel and Palestinians, they keep fighting, there's no other solution to it.
Vanita, there is one more comment from here.
Yes. I'm just skipping to the end of my talk because I think we're done. But please go ahead.
This side.
Yeah, I know that the time's up, is flashing there, but just in terms of collaboration in Ontario, the province I live in Canada, we have a provincial cancer research ethics board. And I think this was in recognition of the fact that very similar multi-center protocols were being reviewed at each center in Ontario. A lot of duplicated effort was going on. And it took a lot of effort to set up the provincial research ethics board, as you can imagine. But what it means now is that a few people from a few centers can sit on this provincial board. It frees up the research ethics boards at the other hospitals to do other work, and really cuts down on the amount of time and effort people have to put in by having a collaborative effort. And just in terms of the collaborations that are being built up through the cancer grid, that's something that could be something to reduce the time and effort for these types of things.
So what I want to point out is collaborative research, like, I mean, in terms of international collaborations, we'll have to look beyond institutions, because herein we'll have to, I mean, get in clearances from the central committees like health screening committee, etc. So as an institution and as collaborations from, I mean, across India, and this is taking a lot of time in terms of HMSC clearances take some like 6 months. And I mean, over and above, like, I mean, the institutional clearances, we'll have to wait for a lot of these clearances centrally, which are coming in. And then international collaborations, I mean, it's a big waiting time in terms of getting your central clearances in place. So as an institution per se, or through collaborative institutions per se, shouldn't we making a representation to the central bodies in terms of expediting these processes also? Because I think, I mean, these are coming in the way, as, I mean, it's an extreme barrier and challenge to the PIs, because a PI has to fight this case in the like, I mean, win this battle through ICMR clearances and central committee clearances. So we have to figure out a way out of these, I mean, these long waiting times that are being, I mean, made, we like to make the PI wait for. So central bodies have to take up these issues. Institutions have to take up these issues centrally, and probably even that might help.
Absolutely. I'm completely with you. I think this time's up is flashing and it's distracting me. So I'm going to end, but I can't end without acknowledging it's always a group effort. Nothing happens without a group. So I'd like to acknowledge my team. Dr. Kumar Prabhash is the heart and soul of our team and has driven everything that I had shown you. These are the other members. My research staff, some of them are here. Thank you. Couldn't do anything without all of you guys. Our medical oncology residents. I don't know if anyone is here.
They're all seeing patients.
No, this is an acknowledgement of their hard work. No, they do a lot of work. They are really. The medical oncology lab. And my mentor, so Dr. Chu, when I did my training, I worked a year in his lab, and he's the one who brought the scientific bent of mind. Dr. Banavli, who was the HOD when I joined, and now the director. And I think, and Dr. Badwe, who is, many times in between, we almost gave up, and, he called and said, you guys are doing a good job, please continue. So always acknowledgement to them. All the patients and families at Tata Memorial. So just really blessed. I think bottom line is we're really blessed to be working in this institution. Sorry, my family, and I'll conclude. So thank you all.